என்ன யாரு நேற்று இதெல்லாம் பேசி
Sure. Good evening, everyone.
Good evening, Dr. Aruna. Sorry, I was muted there. Sorry, good evening. Yeah.
I thought I had to check my
Yeah.
voice.
So another 1 minute, like I will start there. Another 1 minute. So I'll give a
Sure.
brief introductions about the sessions. Then you start presenting. Dr. Kamlesh Tiwari sir is also joined there. He's ICP Dean. So sir will give like a one words of introductions, then followed by your sessions. Then short case discussions, 2 cases we'll discuss. And finally open up for the discussions. I'm just showing some instructions to the candidates here right now. I'm just showing projecting it there. On 1 minute, we'll start at 7:30. Yeah. Which one? Remove பண்ணுமா இப்ப பாருங்க more. Good evening, one and all. So this is a great pleasure for me to invite the second session for the short course in tropical diseases and infectious diseases course. First session was conducted by Professor Chandrasekhar. This time we are having a senior, well-known clinical microbiology and infectious diseases, Dr. Aruna Pujari from Beach Candy Hospitals joining today. I sincerely thank the ICP as well as AP for giving this wonderful opportunity. I now invite Professor Dr. Kamlesh Tiwari sir to give his words of introductions, words of wisdom to before starting the session, sir. Kamlesh sir.
Good evening, friends. We are doing this short certificate course, and this is the second week. And today we are going to do infectious disease. Dr. Suresh Kumar is master teacher for this class. We are doing very well, and especially Dr. Suresh Kumar is doing marvelous job for this session. Dr. Suresh Kumar, please.
Sure, sir. Sir, thanks for your encouraging words there. So a couple of instructions before we start. I'm going to show a couple of instructions because we want to assess the students' knowledge during the session. We are planning to do after the process is over, but during the sessions, this is somewhat pre-test assessment we can do. Very simple questions we are going to put now. So how to do the thing, I just show a couple of instructions. So people who join, just follow the instructions. First thing you need to, I'm going to show on QR code scan. You just scan the QR code so that you can go into the polling questions when the polling questions is going to shown at the end of presentations. The flow of presentations today, after the instruction is over, Dr. Aruna will present for next 35 to 30 minutes. Then we'll show a couple of cases with polling questions. For that, this QR code is going to be useful, not for first presentation. More study related contents also will be shown now, and send whatever future topics and future presenters also. If you want, you can go a suggestion so that we can contact the faculties also. Those who are interested to have hands-on experiences like rounding experience to see the patients, yes, we are welcome. But the only thing, you need to come to Chennai to rounds with us. And those who are interested to present the cases, instead of we presenting the cases for the next sessions, we'll ask the participants, you can present the case to the faculty. The faculty can have the answer sessions from the next session onwards, sir. So this is the plan right now. And this is a QR code. You need to scan either the QR code, or you can go to your web browser and start typing woolclap.com and put the password MCBUI, so that when the question is answering, you can keep the QR code ready. I just give a minute so that people who are joined late scan this QR code and keep the QR code ready. Once a polling question is open after the session, not before sessions, after the sessions, you can participate in the poll. We are not going to ask major questions, only a couple of questions, because we don't have time. You need to interact with the faculty as much as possible after the polling questions is over. And this is a guidelines. We are going to put it in the WhatsApp group. So those who have not read this guidelines, please try to read. This is one of the good guidelines for how to use a microbiology laboratory for the clinicians, and a lot of study materials also we are going to post related to the discussions what we are doing today there. So the WhatsApp group will be active hereafter. Whatever things you want to see here. So this is a WhatsApp group also. You can scan the QR code and for the QR code there. So with this 5 minutes of introductions, my privilege to introduce Dr. Aruna Pujari. She is a clinical microbiologist and infectious disease at Breach Candy Hospitals, good friend of mine, very good experiences, and she has got a lot of publications and a credit. So without further ado, I just stopped sharing my slides and asked Dr. Aruna to share his slides 1 second before. Yes, Dr. Aruna, this is stage set for you there. Please share your slides and start presenting your talk.
So thank you, Dr. Suresh, for giving me this opportunity to take this session. And thank you, Tiwari sir, and AICP for giving me this opportunity to be here and the API team. So I'm going to be talking about clinicians and microbiology. What do you need to know for better infectious diseases diagnosis? So what I'm going to be basically trying to do, these are the learning objectives. I will try and emphasize upon the role of microbiology lab on managing infectious diseases. The importance of pre-analytic phase in the microbiology lab. This is something probably a new terminology to all of you, and yet a very, very important stage, both for the bedside team as well as for us in the lab. I'll also talk a bit about the various testing strategies in the microbiology lab. Touch upon some interpretive criteria for microbiology, particularly the culture reports, because these are the most common reports that you are going to get in your hand, and you will be hunting them over a period of time. And I'd like to introduce the term diagnostic stewardship, a very, probably a recent terminology, something which supports our antimicrobial stewardship programs and helps us utilize antimicrobial agents better. So really speaking, the microbiology lab plays a very important role in the management of infectious diseases, right from providing confirmatory tests, test results with the help of cultures or with the help of molecular methods or PCRs, where we could identify organisms or pathogens, to supportive diagnosis in the form of serological based assays. And clinical microbiology actually is a very vast subject with plenty of subspecialties like bacteriology, mycobacteriology, mycology, virology, parasitology, immunology, serology, as well as molecular microbiology. So what we want to really do is basically, as microbiologists, we want to provide reasonably accurate identification of pathogens, whether it is with the help of cultures or with the help of serological assays or with the help of molecular assays. We want to be able to provide accurate ID to pathogens. We want to assure susceptibility to drugs of choice depending upon site of infections. So I do not want to give you a drug susceptibility report which has tigecycline written on it for a urine sample, because I know that tigecycline does not reach the urine. So my drug susceptibility reports should be such that they would have antibiotics which will reach the site of infection. Also, we would like to reliably detect possible drug-resistant mechanisms. It's impossible to identify all the different types, but whatever is common, at least we should be able to identify. We would also like to provide antimicrobial susceptibility data trends to help formulate the antimicrobial stewardship policy or the empiric policy. In addition to that, with the various methods that are available to us in the microbiology lab, We could also measure host response to infections. This is basically by estimating antibodies, something that we did a lot during COVID time, and we've been using it also for over a period of time. Other than that, we also support in monitoring treatment. For example, performing viral loads for, let's say, HIV or any of the bloodborne viruses, or for CMV, and so on and so forth. So these are the key responsibilities of any microbiology team or the microbiology lab. Now, the moment you enter into the microbiology lab or any laboratory per se, we have what is called as a diagnostic cycle, where pre-analytic phase, analytic phase, and the post-analytic phase are the three key phases where in which the laboratory really operates. Now, what is really the pre-analytical phase? The pre-analytical phase is really speaking the time when, from the time where samples, you think that you need to collect the sample, up to the time where it comes on our table in the microbiology lab and we actually start working on it using different test methodologies. Once we start doing the testing, it is the analytic phase. And the post-analytical phase is basically when we want to give you the results, and how we are going to communicate the results to you is what basically is the post-analytic phase. Now, why one should know about these phases is because the pre-analytic phase is a very notorious phase, and close to 70% of errors that happen, whether at the bedside or in the lab, happen in the pre-analytic phase. And therefore, it's very, very important for all of us to understand the significance and the importance of the pre-analytic phase. So here comes the time when you have already taken the history, examined the patient, and now you have some kind of differential diagnosis in your hand in terms of the syndrome, in terms of what pathogens could be part of the syndrome that your patient has presented with. And therefore, you would also have in your mind a set of tests which you would want to ask for. So based upon the pretest probability, you would analyze the results of the test subsequently. Then one should also know about the sample rejection criteria, because this is very important again, because if you are sending samples which your lab is going to reject, we waste a lot of time. And this is crucial waste of time, in fact. So having an understanding of what all different samples your lab rejects is very, very important. Then what is the appropriate time to send samples is also important. And what are the samples that are needed to be sent for particular tests that you select is also something that we need to understand. So let's look at first the sample rejection criteria that usually most microbiology laboratories would have. So we will not accept urinary catheter tips or endotracheal tube tips, saliva for sputum cultures, blood which is collected in the vacuoteners for blood culture. We wouldn't take swabs for AFB culture, swabs for anaerobic culture, even stool or sputum samples for anaerobic culture, and also superficial swabs from long-standing non-healing ulcers. Similarly, we discourage any kind of collection of urine specimen from the urine bag, or any kind of specimen collection from long-standing drain tubes or pigtails, because these are all going to be colonized. They are not going to be, whatever pathogens we recover from them or organisms we recover from such specimens are not pathogens really. They're basically colonizing flora, and they will skew the interpretation at the bedside. So best practices that to get the most of the microbiology lab in the pre-analytic phase would be based on history taking and the examination, localize the syndrome, identify or have a list of the possible pathogens based upon the syndrome, know what tests are available to you, maybe within your own setup, and which are crucial to be probably outsourced. Collect the samples prior to starting antimicrobial therapy. This is especially important if we are going to send cultures, because the moment you have given even a single dose of antibiotics, some of the organisms get compromised, their viability gets compromised, and we may not be able to grow. And a classic example here would be Streptococcus pneumoniae or Haemophilus influenzae, which so many times, despite them being important pathogens causing pneumonia, we wouldn't be able to isolate from sputum samples. Do proper skin antisepsis at the site of collection, because this is very important. Again, if skin antisepsis is not correctly done, it leads to blood culture contaminations. It could lead to contaminants or skin colonizers growing in pus samples or other important specimens, send deep tissue or pus aspirates instead of sending swabs, and send site-specific samples and know the TAT of whatever test you are going to be asking the lab for. So TAT is turnaround time, and in microbiology, every test has a different turnaround time. So cultures can have a longer turnaround time. Also have some rapid tests, which I'm going to also describe in the coming slides, which will have, probably just an hour or less than that sometimes. So know the TAT of the samples that were of the tests that you are going to be sending, so that you'll be able to track it. All this only so that you finally, when you get the results, you will be able to take actions on those results. And this is a very good time and opportunity for you to discuss with your microbiologist and also provide them with some history, because that's again something which is very important for us in the lab to be able to, develop our own thought process and thinking, particularly when it comes to syndromes and what could be the possible pathogens. So what are the common specimens that we receive in the lab? Urine is one of the most common specimen, in fact, followed by stool, blood cultures, pus aspirates, tissue samples, sterile body fluids like ascitic fluid, pleural fluid, pericardial fluid, CSF, then skin, nail, hair, and corneal scrapes. We also receive devices like the central line. We also receive implants from periprosthetic joint infections. So a whole lot can be done from the various variety of samples that we receive. And as you see, unlike maybe biochemistry and hematology, where 95% of the samples are blood tubes or vacuolators, in microbiology, like histopathology, the 95% of our samples are actually varied. And for this reason, it is very, very important that the request form is properly filled with what is your clinical diagnosis, with what is the exact specimen that you are sending, what site have you collected this specimen from, if there are any ongoing antimicrobial agents, what kind of tests that you might want to ask for this particular patient and this specimen, and have a little bit of history written there, so that it will all help us to support you in the proper diagnosis of the pathogen. So that's all about the pre-analytic phase. On to the analytic phase, let's see what tests are available to us, to you in the microbiology laboratory. So I will divide this into what are the rapid tests that are available and what are the conventional tests that are available. And what do I mean by rapid tests? Rapid tests are those tests which are available within minutes to about 6 hours, typically called as the 0-day diagnosis. So we have plenty of wet mounts that we do from stool, urine, bowel, or hanging drops for darting motility for Vibrio, all spot diagnosis, which can be made very, very easily within a very short period of time in less than half an hour. 10% KOH mounts and calcofluor mount, which is calcofluor is basically a fluorescent stain for filamentous fungi, and potassium hydroxide is, this is, as you see here, this is a typical fungal hyphae that is seen. So these are something, this is something which is available even to a primary level lab, especially the direct mounts as well as potassium hydroxide. For calcofluor, we naturally need a fluorescent microscope, but very simple assays, and they can give you spot diagnosis for certain things like parasites in stool, or pus cells in the urine, or organisms, motile organisms in bowel. So they are very important rapid tests. Then we also have plenty of stained smears that we see. Typically the gram stain, which is so important for respiratory specimens, for CSF, where if we see gram-positive cocci, which are in pairs, we suspect naturally Streptococcus pneumoniae. If we see let's say gram-negative bacilli, which are pleomorphic, we suspect Haemophilus influenzae. Then there is the Zeal-Nielsen stain, or the AFB stain for mycobacteria. While we cannot distinguish between Mycobacterium tuberculosis complex or the non-tuberculous mycobacteria just on the basis of this stain, we can definitely say that there is mycobacteria, and based upon the samples. For example, if you get a tissue sample from a laparoscopic non-healing wound, and you see acid-fast bacilli, it's very likely that these are basically non-tuberculous mycobacteria, because in India, at least, NTM is endemic to surgical site infections caused by minimal access surgeries. Similarly, a modification of the Zeal-Nielsen's is the 1% acid-fast stain, where with the help of which we can identify a whole lot of opportunistic parasites in stool, like Cyclospora, Cryptosporidia, Isocystospora belli, and also nocardia. As you see here, these are very thin branching filaments typically seen in the sputum. Then Gimsa and the Leishman stain can be used for parasites as well as fungi like malaria, filaria, as well as Pneumocystis xyrovisi. So these are the typical cysts of Pneumocystis xyrovisi coming from a Ball specimen. And there are some fluorescent stains, not often used, but AFB fluorescent stains to detect AFB or acid-fast bacilli is used in large settings where they screen a large number of samples, not very commonly used in routine clinical microbiology settings. Apart from that, using whole blood or serum, there are plenty of rapid diagnostic tests that are available for bacteria, viruses, and parasites. For example, malaria antigens, for leishmania, for dengue, for a whole lot of viruses as well, and as well as for candida. Then there are urine antigen tests for Streptococcus pneumoniae, Legionella, Histoplasma, which can be done, from a non-invasive specimen like the urine. These tests are very quick, and they are mainly diagnostic in nature. Then from the CSF also, there are CSF antigen-based tests. Typically for bacterial meningitis, you could have a single target or multiple target-based tests, which includes Streptococcus pneumoniae, Haemophilus influenzae, as well as E. coli. That's a multiple target agglutination test. Then for cryptococcal meningitis, there are tests which are available in the CSF, and that could actually help in early diagnosis of cryptococcal meningitis. In addition, there are those were all the antigen-based tests. Now moving on to antibody-based tests, we know that antibody-based tests are basically the host responses, but we use them a lot again for a whole lot of organisms like Leptospira, Brucella, Mycoplasma, Rickettsia, and viruses like chikungunya and the bloodborne viruses. So important to note here is that here we are measuring the host response. A lot of rapid diagnostics in terms of the card tests are not very reliable, particularly when it comes to dengue. But they are used in other situations, for example, in Leptospira or Mycoplasma, or for the bloodborne viruses. These are mainly diagnostic in nature. They do not have any role in prognosis. And very important is that you cannot do these antibody-based tests probably in the first week of infection when you are suspecting the infection. So if they have to be done in the second week, for a typical example would be for chikungunya, this test needs to be done only in the second week, because antibodies will take at least about 7 days to develop versus versus your molecular tests. For example, chikungunya PCR would be positive in the first week. So it's also important to understand the basic concepts of what kind of at what level you are going to pick up the pathogen, whether you're going to pick up the direct pathogen with the help of antigen tests or PCRs or cultures, or you want to detect the host response in the form of antibodies, particularly in organisms which we may not be able to grow or we may not be able to pick up by other methods. Then another very beautiful test that we now have are the syndromic PCRs. Again, this is very rapid. It's about 1.5 hours, and we can target a variety of syndromes. For example, the upper respiratory tract, where viruses and atypical bacteria are there. Post blood culture bottles coming positive with drug-resistant genes, fungi, bacteria being present. Then lower respiratory samples like sputum, ball. Here again, both bacteria, atypical viruses, atypical bacteria and viruses are present. In addition to drug-resistant genes, the common ones that are present here in India, for example, to detect MRSA, VREs, or for that matter, carbapenem-resistant genes. Then we have a 14-target multiplex panel for CSF, which has bacteria, viruses, and fungi. Then there's also a gastrointestinal panel with 22 targets of bacteria, viruses, and parasites. And the most recent one, that is a bone and joint panel with 39 targets, comprising of aerobic and anaerobic bacteria, fungi, and also drug-resistant genes. So these are most of these, excepting for the blood culture panel, all the other panels can actually be done directly from the specimen. So if you send a BAL specimen where you're suspecting a pneumonia, and you run the test in about 1.5 hours, you'll be able to identify a whole lot of community as well as hospital acquired pathogens along with drug resistant genes. So it makes a lot of difference if you have such kind of methods or tests available to your disposal, particularly in the intensive care unit. Then there are also some rapid culture-based methods which are based on chromogenic agar, typically for MRSA, for carbapenem-resistant enterobacteriales, also for Candida. And these are screening assays. So if you have a liver transplant unit, or if you have a bone marrow transplant unit where you want to do screening for carbapenem-resistant organisms at the beginning, then Chrom-Agar, which gives you results in about 18 to 24 hours, serves as a good way of identifying these pathogens very, very easily. So as you see here, basically it is the different colors. The organisms, different organisms are detected by different colors, and that's how the chromogenic agar is really used. So what is the role of these rapid tests in our antimicrobial stewardship programs? According to this particular paper, which was published in Clinical Infectious Diseases in 2022, these in the entire patient care pathway, your rapid tests are very important, right? From the initiation stage to the treatment stage, and then followed by the de-escalation phase. Any of these rapid diagnostic tests will be play a very crucial role when managing your patient through the entire patient care pathway. Now we move on to the conventional methods that we have in microbiology, and the most important, or the gold standard, or the backbone of any microbiology lab today still remains the culture tests, which have a turnaround time usually of about 48 to 72 hours, but they can be longer in situations of blood cultures, which could be 7 days to 14 days to 30 days also. It could be longer in bone and joint specimens, typically from 7 to 14 days, particularly if you are suspecting organisms like Cutibacterium acnes. Then we also have ELISAs, manual ELISAs, with the turnaround time can be 1 to 3 days, depending upon batches and volumes. And we do it for organisms, meaning for leptospira. For dengue, we have both the antigen as well as the antibody ELISAs. So these are two common manual ELISAs that are done by most microbiology labs. Then we have open PCRs, which have turnaround time depending again on batches and volumes from 1 day to 5 days. And then we have the recent, the new kid on the block, I can say, is the sequencing platforms, where depending upon whether you are doing long read or short read sequencing, the turnaround time can be anywhere from 2 days to 14 days. So the next few slides, I'm going to talk a little about cultures and antimicrobial susceptibility reports, because this is again something, as I mentioned earlier, probably everybody runs, to identify what is the organism that is growing and what is the susceptibility. And many a times people don't find this. So many times my residents keep calling us that this report is not updated. When is it going to come? So this is something that takes time, and often everybody is hunting for the culture and susceptibility report. So if you see a report like this, which has pluses and minuses, it just doesn't require your attention. It should be, actually thrown into the dustbin. This is not the report that a good microbiology laboratory would ever give. So a good culture and susceptibility report would have the site of the specimen mentioned, as I showed you in the request form also. It should also mention about, the stains, that is the grams and the ZN stain. ZN stain, particularly if it is a respiratory specimen, if it is pus, if it is an aspirate or fluids, or tissues, the ZN stain is very, very important. Then colony counts, if it is urine, the name of the organism should also be mentioned. And the interpretation, that is susceptible or resistant or intermediate, with or without the MICs, which are numerical values. So it could be with or without them. Nobody is saying that, disk diffusion is redundant. Disk diffusion is still an important way of testing susceptibility. And it's only for a few drugs that MICs are absolutely mandatory. So that's what should be, that's how your susceptibility report should really look like with all of these above components. And this really comes from, we follow two guidelines, either the CLSI guideline or the UCAS guideline, to basically give you these interpretations. And it therefore cannot be based on plus and minuses. So just highlighting a few important AST interpretations. So if you have a report which says Staphylococcus aureus, your attention should first go to whether there is cefoxitin on the list. If cefoxitin is there, find out whether it is cefoxitin susceptible or cefoxitin resistant. If it is cefoxitin resistant, then automatically this isolate becomes methicillin resistant Staphylococcus aureus. And in that situation, all your beta-lactams and your first and second generation cephalosporin, third generation cephalosporins, everything becomes resistant. We do not need to test it. Automatically, if it is an MRSA, your penicillins and your first, second, third generation cephalosporins will become resistant. Then the next step to look at in a Staph aureus report would be a D-test for inducible clindamycin resistance. And as you see here, this is important because even if your clindamycin is susceptible, but there is a D-test which is positive, you cannot use this clindamycin because it will eventually become resistant. Similarly, in an MRSA, vancomycin has to be reported in terms of MICs. You cannot report it only with the interpretation or a disk diffusion criteria. It has to be reported in terms of MIC. So these are some very important points when it comes to a report which says it is Staphylococcus aureus. If you have a report which says Streptococcus pneumoniae grown, then important to look at these two drugs and interpret based upon the site. So if this Streptococcus pneumoniae has grown from the CSF, then the criteria for ceftriaxone and penicillin interpretation is very different from those that may be grown from non-meningitis sites like the respiratory tract or from the blood. So this is again something, if the microbiology laboratory follows the CLSI guidelines, it will naturally interpret it according to the site of infection. Then if you have organisms like Enterobacter cloacae, Klebsiella aerogenes, or Citrobacter frundi, these tend to produce moderate to high amounts of AMPCs enzymes. These are enzymes which will actually hydrolyze your penicillins, your cephalosporins, first, second, and third generation, and it will also hydrolyze your piperacillin, meaning your BLIs like amoxicillin clav, piperacillin tazobactam, as well as cefoperazone sulbactam. So even if your reports indicate susceptible, if you have these organisms, avoid using these drugs because in vivo they might become useless. Then if you have reports of either E. coli, Klebsiella, Pseudomonas, Acinetobacter, and there is colistin mentioned there, if it's an XDR pathogen, then colistin has to be reported once again in terms of MICs. And usually we do not have a susceptible or a resistant breakpoint for MIC for colistin. It will always be reported as intermediate. Of course, if it is resistant, has a high MIC, then it will be reported as resistant. But typically, we do not have any susceptible breakpoint. So even at 1 or less than 1, it will always be intermediate. So how will we use once these results have been done in the analytic phase? Now comes the post-analytic phase, and this is the time where the results will be passed on to you, and you will be able to utilize these results. So how do we really pass on the results? We could have manual reports or interface results. So many a times, if we have systems or devices like the Vitec or the CLIA systems, then most results are interfaced. We do not have to type the results. And why is this important? It's important because when you type things manually, there are a lot of errors that can happen. So once again, in the post-analytic phase, we want to avoid any kind of typing errors, and therefore interfacing of results becomes important. Then we also do cascading of AST results. For example, if you have a Staphylococcus aureus, which is isolated from, let's say, a pus aspirate, and now this is MSSA, that is methicillin susceptible. In methicillin susceptible, I know that there is no role for vancomycin, teicoplanin, or linezolid. So I might actually suppress that result and not give that result on the report. So, that kind of cascading and suppressing of drugs also is done by the microbiology laboratory. Mainly, the intention is that we utilize appropriate antimicrobial agents based upon whichever site is involved and based on the concentration. Then when it comes to PCRs, particularly the multiplex PCRs, they are very, very sensitive assays, the multiplex syndromic panels that I mentioned. Here, it is important to understand that some organisms might be picked up, but they are really not pathogens. For example, in the CSF panel, occasionally we might pick up HHV6, or we might pick up CMV. So here, it's very important to understand and know the history of the patient, because these might actually be just silent pathogens, silent organisms that have been picked up because of a very sensitive test. And they are not really the pathogens that are involved in the disease process. So that's something which once again gives us an opportunity to interact and communicate with each other. Then understanding contaminants. As I mentioned, if a sample is sent from a Euro bag, we are going to grow simply contaminants and not really the important pathogens. Similarly, there could be polymicrobial flora. So if a urine sample is not appropriately collected and a midstream sample is not given to us, then there again 2-3 different types of organisms can grow. And we know that if there is an infection, usually there is one single pathogen that predominates. So in the post-analytic phase, it's very important to have good communication between each other, the bedside and the microbiology team, in order to be able to really act on those results. So how do we utilize the post-analytic phase to get the best out of microbiology? Check the reports based on your TAT. Inquire if there are any delays. There might be some specific reasons for delays, so always better to call up. Review to understand whether this is a pathogen or a colonizer, whatever test result you get. And if the result does not fit in clinically, please communicate with the microbiology team ASAP, because there is a possibility that we might be able to help you with some additional tests to really understand why it is not fitting, or we may be able to support you with some different ways. So communication here is also very, very important. Now the last bit of my talk is on basically diagnostic stewardship. So we've gone through all the 3 phases in the microbiology lab: the pre-analytic, analytic, and the post-analytic phase. And all of this is involved with diagnostic stewardship. So it really means ordering the right test for the right patient at the right time to inform optimal clinical care. There is no point in having a report if you are not really going to act on it. So having the microbiology report, the next step should really be taking action on those results. And that's what really diagnostic stewardship really means, that based upon the results, you need to take action, whether it is escalation, whether it's de-escalation, or whether it is, simply taking any other steps towards maybe removing a device or changing a device. All of these actions, which are when it is based on the microbiology result, is part of diagnostic stewardship, and that itself is a part of antimicrobial stewardship, which, as I mentioned earlier, is something which is very important in today's day and time, when we encounter so many antibiotic resistant organisms, and we are trying to, or rather struggling with using our antimicrobial agents more judiciously. So finally, the key take-home messages are that a good microbiology service is a great support to managing patients of infectious diseases. Pre-analytic factors are very, very important to ensure accurate results. So if you give me any kind of urine sample which is not thoroughly a midstream sample post cleaning the part, I'm going to grow colonizing flora. Microbiology has rapid and conventional methods for detecting pathogens, and keep your communication open. Discuss at whatever time, at whatever opportunity that you get with your microbiology team, because this is critical to help optimize your patient management. Thank you so much.
Thank you, Dr. Aruna, for your wonderful presentations, giving the key concepts of microbiology to the clinicians. The come of the key messages, what she told, the turnaround time we need to know. Before you interact with the microbiology lab, we need to know the turnaround time of whatever samples. People always send the blood cultures and wait for 5 to 7 days. But nowadays we are using automatic system. Daily we can. In fact, infectious disease doctors go to the microbiology in the morning before they start rounding. What are the cultures I sent yesterday? What is growing today? Can you tell? This is how our round starts there. And second thing, she clearly told the colonizers an unnecessary sample like tips. Some of the questions come in the chat box. We'll ask you in the later. So what about the tips? Usually don't send urinary catheter tip, drain fluid, even wound swab always take with a pinch of salt. So don't send tips and everything. That's very good message she conveyed. And third thing, we need to know good clinical history we need to provide to the microbiology lab. If you want to get a good results, garbage in, garbage out. If you send a good sample along with a good history, you can get a good results as well as more information from the lab. That's most important thing. That's what ID and micro usually do the thing. Whatever things we usually communicate with the microbiology lab, and micro will communicate whatever final details. So to get more informations, you need to interact with the microbiology. That's a basic message. So what I'm going to do in next 5 to 10 minutes, we'll run a couple of cases. Before that, I'll give an instructions. Again, one more time. So people, those who are not joined early, you can just start seeing. It's not coming. Yeah, it's coming. Okay. So this is an instructions for the QR code you need to scan. This QR code you can scan. If you're not able to scan the QR code, go to your web browser, type this website woolclap, woolclap.com, and put the passcode MCBUYK, so that couple of questions can be asked in the poll. We want to check the participants. Those who are applying for a certificate course, they need to answer this type of questions so that the active interactions can be monitored. And couple of references materials. We are creating a references material for each topic, not only one PPT. For example, microbiology and infectious diseases, what are all the things you're supposed to learn? We are creating a couple of files, couple of references materials for you so that you can read in a leisure time next 1 week or not. With one PowerPoint presentations of 30 minutes, you're not going to learn. So what we are going to do, what is the key references material? What are the book chapters, not books, book chapters, and what are all the good references guidelines? For example, this is a reference guidelines we are showing for microbiology laboratory diagnosis. This is latest one. So this type of guidelines you need to read so that your post-certificate examinations will be based upon this type of references material. We are going to post it right now. And people keep on asking about how to join the WhatsApp group. We created a code. This is for WhatsApp group, not for the exams question today. That's why I don't confuse this one. I'll show a little later. Okay, right now what I'm going to do, I'm going to start the small presentations, practical cases, not whatever Dr. Aruna has shown is a good theory for you to understand. Right now I'm going to show a couple of good cases for you. One second, I'll just start it. Yes. So diagnostics test, what clinicians need to know that we need to show practical cases I'm going to show right now. My disclosures, no shares in the lab. My mind is laboratory, people think, but usually without laboratory, the clinician is without any arms. When you go to the war, we need to have some arms. Without arms, you can't fight. So laboratory is a harm for you to fight the infections. So this is the last slide Dr. Haruna Pujari shown. Right test, right patients at right time with the right sample. That is more important for you in diagnostic stewardship. So this is a poll questions. I'm going to ask the poll questions right now. So this is a 32-year-old male, no comorbids. Patient has got fever, cough of 3 days durations, mild sore throat, running nose. Traveled to Kumbh Mela and came back now. On examination, patient is febrile, 99.5 degrees, mild congestions in the throat, but tonsils are not enlarged. Respiratory systems was clear. Other system examinations was normal. I think the case is shown clearly. So what test can you do for these patients? How many want to do CBC? How many say throat swab, X-ray chest, no test, start antibiotics? These are all the choices given. I hope the case is clear. So I'm going to run the poll right now. Yes, those who scan the poll, just go ahead and start answering now. So I'm just giving a lot of time there. So this is a 32-year-old male with presence of fever and cough. He went to recently Kumbh Mela and came back. Right now, throat is congested, low-grade fever is going around. Other system examinations and respiratory system examination was normal. So what test, whether you want to do CBC, whether you want to do H1N1 PCR, X-ray chest, no test or antibiotics. So what do you think? So just put it in your answers so that we can see. I hope only one person answer or people are answering. Others finding difficulty to answer, I do not know, but I just check the poll. Let me check. Others are not answering. I'm not sure why the issue is there, but we just check. Okay. So when to investigate a patient, that is most important. What is the right patient? That's most important thing in your practice. What is the right patients? When a patient is sick, we need to investigate. When the patient is stable, particularly acute febrile illness without any localizations, when a person is stable coming to your OP, most of the time it is viral. Particularly the history shows clearly he went to a crowded places. He got a viral infections, probably minor infections without any comorbid conditions. There is no need to investigate. This is a beautiful paper from one of the small hospitals in southern India. They didn't do for a patients with the acute fever without any localizations. First thing they want to rule out any sepsis. They are answering in the WhatsApp, but instead of answering in the WhatsApp, you need to go to the poll code because people mostly said 4. So most of the answers, but you, instead of answering in a chat bot, you need to go and click the answers in the poll itself. Next time, make sure the next case, no problem. So this study from one of the small centers showed when a person has got acute febrile illness without any localizations, without septic or without any major comorbid, you can wait for 3 days. Most of the fever will subside. No need for antibiotics, no need for test. So we need to know which patient to send a test. That is very vital for your practice. Then come all the common things I shown here. For example, when the person has got fever, sore throat, hoarseness of voice, we need to make a syndromic diagnosis. Speaker clearly told, make your syndrome, accordingly you can test. Here there is no test. If you really want to test, when the person is sick, when the person has got some comorbid conditions, yes, we want to check, we can do the throat swab. On the other hand, for rhinitis and sinusitis, if you think most of the time the fever will subside, the symptoms will improve, no need for any test. For example, if you think urinary tract infections, you need to do urine protein along with urine cultures. Before that, check whether symptoms of urinary tract infection is present or not. Whether the person has got dysuria, urgency, frequency, lower abdominal pain, blood in the urine, you need to have these type of symptoms before you ask for urine cultures. When you ask for urine cultures, always send urine routine. If urine routine does not show pus cells and the clinical history is vague, there is no point in asking the test. So this is very vital. What test? So the second R, what patients I shown previously, what test? This is a test based upon your syndrome, what you think. That is what she clearly told. Write your diagnosis, what you are thinking to the microbiology lab. So this is my second case. You need not answer in the WhatsApp. You need to go into the poll. So you need to go to the woolclub.com and use the code MCB UYK, I think so there, MCB UYK. So woolclub.com, MCB UYK, that's a passcode. So this is a salesperson, 24-year-old male, fever of 9 days and constipations. On examinations, febrile, spleen was present, no jaundice. WBC count were normal. Essential tests were done because fever is going for 9 days. That is why they did a basic investigations. MPQBC was negative. Clinician was suspecting typhoid. So what test will you do? Right now, chat box is answering this type of questions. Please answer in the poll, not in the chat bot. Go to the wool clap. This is a code MCBUYK. Answer in the poll itself. You can just open the web browser, go to the Google search with the woolclap.com, put your code MCBUIK, you can get the answers. You can get this poll questions, answer in the poll questions. I'll wait for a minute people to answer there. So whether you want to do Vidal test, whether you want to do a complete blood count, whether you want to do a typhi.IgM, whether blood cultures and sensitivity, minimum one set of blood cultures, what do you need? So just see the thing, answer, okay? I'm still people. Okay, I think some difficulty is there. People are asking about vital test, but speaker can answer. But usually one single vital test has got very little value because we do not know whether what is the significant titer 1. Lot of non-typhoidal salmonella also can cause positivity. Even enterobacteriaceae can cause positivity of the Vidal. And how long the Vidal is going to remain positive, we do not know the data. So don't go with this Vidal test alone to make a diagnosis. Both the sensitivity and specificity, that is why WHO guidelines almost removing single Vidal test to make a diagnosis of removing the Vidal test from the diagnosis of typhoid. So we need to know the right test. Right patients we need to know, right test is also we need to know. Simple laboratory without culture facility, do the CBC. That thing, eosinophil count, eosinopenia is a marker of typhoid, but that is not 100%. It has got sensitivity of 70% to 90%. It is reasonably sensitive, but specificity may be lacking. But this is a good test for a lab without microbiology lab. Use this test. When to ask for a culture. Before that, you need to have a clinical pictures and do it. That's more important for you. Okay. So this is all the simple test. So right volume, the third thing is right volume or right sample, I can put it there. So right patients, we have shown patients who got infections. Second thing, right test, we need to know for which patients. For example, typhoid blood cultures. But for blood cultures, we are not getting positivity. People say, I always send cultures, blood cultures to the lab, but blood cultures are not came back positive. What is the reason? We are not sending adequate volume. For example, blood culture means minimum 7 to 10 ml of blood in a bottle. Minimum one set the patient is in the OP settings. Ideally in IP settings, 2 sets. The person is sick, we can send even 3 sets. That means 40 ml to 60 ml of blood. If you send, the yield is very high. These are all the paper shows how much blood you are sending, what is the positivity rate. So keep in mind, outpatient setting minimum 2 bottles, 1 bottle of aerobic, 1 bottle of anaerobic. In case of IP setting, 2 sets, 4 bottles we need to send. If you think endocarditis or sick ICU patients, even you can send 3 sets of blood cultures so that you get a positive results. So how to make a diagnosis of typhoid? Based upon the history, based upon the clue of CBC, eosinopenia, ESR normal, and culture is a gold standard. Vidal is not a gold standard. Some of the lab tests has got no value to me. For example, single Vidal. MAN2 and IGRA to make a diagnosis of active TB. It indicates latent TB. Leptospirosis test and scrub IgM, all serology, don't do within first 3 to 5 days, particularly antibody test, because body should recognize and produce antibody. That will take time. So don't do any serological test first 3 to 5 days, and always take with a pinch of salt when you interpret the serology. That's more important. CRP and procalcitonin, to start antibiotic, it has got no value. To stop antibiotic, it has got value. Starting antibiotic has got no value. Wound swab, particularly without proper sampling, don't send wound swabs. Urine cultures without urine routine, very difficult to interpret. And sending 2 ml of blood, 3 ml of blood for blood cultures. Similarly, if you want to make a TB meningitis, adequate CSF, volume is more important. And similarly, if you want to think endocarditis, transthoracic has got limitations, whether we need to go for a transesophageal, particularly prosthetic valve. ASO titers, lot of tests. For example, ESR and CRP, people are calling zombic test. Please don't do unnecessary tests and put a pressure on the microbiology lab to get the answers. These are all the simple algorithms we usually follow in our practice to make a diagnosis of dengue, typhoid, lepto, scrub. how to make a diagnosis. You can take a screenshot. We can share this information afterwards. And for malaria, the best test is malarial parasite. But wrong test, there is no clinical malaria. Always malaria needs test, either peripheral smear, or you can go for a MPQBC, or we can go for PCR, but don't go with clinical malaria diagnosis. Typhoid means either eosinopenia is a poor man lab, blood culture is gold standard. Scrub typhus, the chances of picking initially is a bit difficult. Clinical diagnosis has got value. Influenza means PCR. Don't go for rapid antigen test. Dengue means either PCR in initial days or NS1 in couple of days. Right time also you need to know. And for example, TB, expert MTB along with AB culture. HIV, go for a 4th generation ELISA. UTI, symptoms, urine routine, urine cultures. Acute gastroenteritis, always if you want to make a diagnosis, PCRs has come up, but stool routine is minimum requirement there. But keep in mind, whatever test you are asking, your patient should have money. Indian patients are paying from the packet. That's most important. To join the 100-degree WhatsApp group, this is a code we need to scan. And those who are further interested, I'll ask permission of Dean to include in the course because we already reached the mark. Those who are extra interested, please contact us. And we are planning to have 1-day CME in March on the day of World TB. So with these presentations, I'm going to ask a couple of questions I already raised in the chat board to our speaker. One second, I just exit my screen and come back in a minute. Okay, sure. I stop sharing my slides. Dr. Aruna, first question is they're asking about central line tips. You're talking about the tips I don't recognize. I don't want to entertain. But what about the central line tip? One of the participants is asking about central line tip.
Okay. So normally we do not encourage any kind of even central line tips to be sent to the lab as a routine. But if you are suspecting a central line associated bloodstream infection, or at the bedside you are suspecting a catheter related bloodstream infection which is associated with the central line, and you happen to remove the central line, you can send the distal 5 centimeters of that central line to the lab. This should not be done as a routine. It should be done only in situations where you are suspecting the line to be a cause of a bloodstream infection. But this should not again only be done as sending a central line. You should always send blood cultures. So you could either send two peripheral sets of blood cultures, or you send a central and peripheral set of blood culture and remove the line tip and send the tip to the lab, not as a routine.
The next
That's
question.
possibly the
Yes.
only tip that is accepted. Otherwise, no other tips are accepted.
Yeah. Rightly pointed. Only one tip we can allow, particularly if you think central line and blood cultures has got no growth, you are removing the line, your suspicion is very strong, you can send. Agreed. They are asking about the Vidal. We answered the Vidal. Single Vidal has got limited value. If you really want to do 2 Vidals, but unfortunately the patient will not wait for 10 to 15 days to
Exactly.
make it.
It is not time sensitive actually.
Yeah. The next question they're asking, the biosphere examinations or the respiratory sample showing one bacteria and one virus, how to interpret?
So, the good thing, the lower respiratory panel for the bacteria at least had some kind of quantification. What we have seen and what literature also reports or suggests is that if you have any bacteria which is more than 10 raised to 6 or more than that, okay, so 10 raised to 6 copies per mil or more than that, that you can report it could be a pathogen. We also know that, with the viruses, there could be superadded bacterial infections, particularly if these bacteria, things like Streptococcus pneumoniae and Haemophilus influenzae or Staphylococcus aureus, they might actually be superadded infections. So what we do is in our lower respiratory samples, if there are bacteria which are more than 10 raised to 6 or 10 raised to 6, we report them along with the virus.
So usually think about the pre-test possibility, what you are doing. Sometimes the PCRs can pick up the dead bacilli or dead viruses also. For example, COVID time, initially when we started, we wanted 2 negative PCRs, and we have seen COVID PCR remain positive for long 1 month, 2 months also. So always PCRs take with a pinch of salt. Then third thing they're asking, wound swab, if shows 3 or 4 organisms, how to interpret?
So it's very likely that this wound swab is a superficial wound swab that has been sent from a non-healing wound, and they are colonizers. It is best not to interpret this or not to act on it. It would be better to probably take a deep tissue sample and send that to the lab.
Then they're asking about something called intrinsic resistance, how the clinicians can aware of it, and site-specific intrinsic resistance. Anything you can throw some light. Intrinsic
So
resistance
there's
of
nothing like site-specific intrinsic resistance, but when it comes with respect to site, the concentration of the antibiotic at the site should be there. For example, as I mentioned, tigecycline doesn't get concentrated in the urine, so there's no point using tigecycline in for urinary tract infections. Similarly, but intrinsic resistance is something which is very different. For example, if I were to say Klebsiella has intrinsic resistance to ampicillin, or Stenotrophomonas maltophilia has intrinsic resistance to imipenem or meropenem. So even if your drug susceptibility is showing these as susceptible, you would actually mark them as resistant, and you will not use these agents. So you could have with your microbiology laboratory a chart which is also there in CLSI. It could be displayed in the clinical area to get benefit of understanding which antibiotics have intrinsic resistance to which pathogens.
That's very good. If possible, you can share, because most of the clinicians don't have a good
Sure.
microbiology lab. You can show it to
I
the
will.
participants there. That's fine. So
I'll send it.
regarding antibiotics, they're asking about HAMCs and ESBL. What should be the drug of choice? They're asking about it.
So as I said about for AMCs, basically you depending upon the site of infection. So if they're causing urinary tract infections, if you have fluoroquinolones or trimethoprim sulfamethoxazole or nitrofurantoin, these could be good choices. But if it is a bloodstream infection, often the what is left with you is usually a carbapenem. So avoid any kind of penicillins. Avoid first, second, and third generation cephalosporins. Avoid beta-lactamase inhibitors like piperacillin, tazobactam, cefoperazone, sulbactam, amoxicillin, clavulanic acid. Other agents like cefepime, which is a fourth generation cephalosporin, carbapenems like imipenem, meropenem, ertapenem, fluoroquinolones like ciprofloxacin and Oflox, Levoflox, then trimethoprim, sulfamethoxazole, all of these will work. So you can decide based on the susceptibility and the site of infection.
Thank you. Thank you for your inputs there. Some of the people still asking about intrinsic resistant drug chat and AST reporting something. I just say forward to you there. Once we are free, or just share it there.
Sure.
And people asking about typhi.igm. Typhi.igm is a glorified Vidal we can put it. That's what
Useless.
it has got limitations. CRP, PCT do not start antibiotics. PCT only stop antibiotics has got value. I sincerely thank Dr. Aruna for sending his valuable time in short notice. That's more important than I just call 5-6 days before the sessions. Thank you for your acceptance and did a good job there. And I sincerely thank Kamlesh Tiwari sir for allowing us to do the thing. And sir, this is for your time, sir. You just put some comments on the sessions as well as comments on future sessions also, sir.
I can say it is excellent, sir. Can't be better than this. It is excellent. Thank you all very much. Thank you, sir.
Yeah, so this time we are sticking to the time almost. Thanks for your time and thanks for the participation. First time we overshooted. All the participants, we can keep in touch. We can put it in a lot of materials in the WhatsApp group. We'll update whatever materials from them. This is only tip of the iceberg. You need to read about this topic for the next 5 to 7 days. Then only you can master whatever we are doing it now. With one PPT, it's very difficult to understand of 30 minutes the microbiology lab. But we are providing some support to you. I sincerely thank once again ICP and API for giving this wonderful opportunity, and particularly Kamlesh Tiwari sir and today's speaker. Thank you very much. We'll see you next week with a good topic there.
Thank you so much. Thank you, Dr.
Thank you.
Suresh. Bye-bye,
Thank you.
everyone. Thank you, sir. Kamlesh, sir. Thank you.